or an error in the study designs is that we try and test out these models in groups which are very clean. So let's say if you have a disease condition, and let's say you want to look at maybe one kind of cancer, and to begin with, people may just take in people who have confirmed cancer and have another group, like kind of a cohort or something built in, which clearly does not have a cancer. And you kind of run these models and you could get certain figures on sensitivity and specificity. Now, the problem is that if you have to deploy a model in or any diagnostic in the clinical practice, it has to be done or it has to be tested in the scenarios where it would be used, which means that anybody who comes in with, let's say, a lump or a suspected, cancer, that's the population where it has to be studied. And very often, be it AI, be it, biomarkers, be it, imaging tools, the first step often is to kind of test it out in very clean populations, which I think gives us, I would say, misleading results. It may be okay for the initial development, but I don't think these kind of data would be able to guide the, whether you place it or not. So obviously, you're looking at these statistical terms in terms of sensitivity, specificity, and so on. And again, the exact, let's say, the cutoffs are not good. I don't think we would be able to have very clear cutoffs. But I guess general principles would follow that if for a screening test, one would demand a high sensitivity. And that's basically because very often the sensitivity and specificity come at cost of each other. A highly sensitive test is also likely to have specificity which may be a bit on the lower side. A very specific test may be having sensitivity which may be lower than what is desirable. Obviously, one would strive for something which is 100% sensitive and specific. That's where one would look at. The other thing one needs to keep in mind is that scenarios where you want to where you have a certain reference standard or gold standard, and there are times when you actually want to improve upon it, right? It's something like when gold is really not gold. I'll give you just an example. Maybe when we talk about childhood tuberculosis, if you take the gold standard as microbiological confirmation, even with best of efforts to get the appropriate sample and put in all that we have to get a microbiological diagnosis, we may not be having that yield of more than 40-45%. Yet others you are going to manage on clinical radiological criteria. Now, anything that you test out is going to be, it's going to be a little bit difficult. It's likely to fall short, and which would then bring in the question whether you want to replace that gold standard or whatever that reference standard is. That's another issue. So I would say that we would need a good discussion, or at least looking at carefully the study designs when we look at the sensitivity specificity data. I think we also need to move towards looking at the positive and negative likelihood ratios rather than just sensitivity, specificity, and also the positive and negative predictive values, because the later come are dependent on what kind of prevalence you have of the condition within the population or subjects that you have tested. So there would be multiple aspects. I don't think we can just look at a particular number and say something is good, or it needs to be improved upon. I think we need to look at the entire study design or framework from which the data actually have been generated. Over.
Right, sir. Data cleanliness during training is one of the paramount important. Uh, One last question for you, sir, because you have spared your busy clinical time for us. Uh, this is regarding the explainability of AI. Now, there's a lot of talk about how AI models need to be explainable, they need to be comprehensible. Now, the question is that would you rely more on black box AI model, which gives right decisions 99% of the time, and explainable AI model, which gives 90% right decisions? Which one would you trust, sir?
Yeah, I think that brings in another, I would say, hot topic in the field of AI. The AI, again, I think it depends on a lot on the input data that we are providing, and also many things which the models see, which let's say we do not. And therefore, the entire issue about explainability comes into, the discussion. In our usual way, we want things to be, logical as to how a decision has been arrived at, how a condition has been diagnosed. We would have certain ways to do it clinically or even lab. So, if you're diagnosing a condition, you may have a metabolic pathway which you look at, and you look at aberrations in that, and you could arrive at a diagnosis. Now, on the other hand, we would feed in a large amount of data into a model, and there are multiple, analysis that are going on. Uh, some of them would have what kind of weights have been assigned to each of these analysis within that model. Some of these things are not going to be clear. Now, this is where I guess there's a dichotomy. So we want a model to perform better with a set of data. The same data, if we look at, we get a certain diagnostic yield, for example, but we want the AI model to improve it. So obviously, it's going to look at more than what we are able to look at. Now, only thing is that the explainability part comes into the picture, and I think to an extent it can be taken care of if the models are tested in varied conditions so let's say I'm just giving an example. So if you want to predict shock, for example, in a child in the ICU, and I know that, the parameters that are getting in are basically the heart rates, the blood pressures, the temperature, respiratory rate, and so on. I would have a fair sense that the model is going to use the absolute and the relative values or the changes or the trends in these to be able to predict. So to an extent, I would feel that, this seems to be explainable, that look, this seems to be a scenario where it's looking at certain trends or certain variability aspects which we are not able to analyze on a, let's say, a snapshot basis. So on the other hand, if there was much more data that's getting into, there's some imaging that's getting into, and some of the models, the way we train them, they identify the background which gives them an idea about the critical level of illness of a child versus the actual parameters of the child. So that's where the explainability part would come in. And again, there have been various examples, both in medical and non-medical sites, where the AI models actually have used the metadata and not exactly the data to arrive at a decision or arrive at a label. So I think the explainability part is important to an extent. But at the same time, I would think that if one is able to test out models and varied conditions, varied clinical scenarios, varied, settings, high resource, low resource setting, and every time it seems to perform well, I guess one would be more open to it as compared to something which has only been tested in a particular place, has no obvious explainability. And now, if you want to scale it up, I don't think that would be a good idea, because there would be issues around what the algorithm actually has and how it arrives at a decision making. Other than that, there certainly would be ethical, legal issues and so on, in terms of when things don't go the right way. So I think as of now, one would be, in our usual way of thinking, one would be more inclined to take up a model which maybe the performance is a bit lower than what let's say a black box model may be having. But I guess I think that's how our minds are trained to look at carefully, to find a logical, explainable model to arrive at a particular decision or at a particular diagnosis. But I think one would have to find a way to overcome this. Only then we are going to be having things which are going to be better than what we currently have. Over.
Right, sir. I mean, as clinicians or doctors in general, we cannot just throw away explainability and trust everything on an AI model. That is the message, sir. Thanks for your time, sir. I hope we have not taken up too much of your time, and sir has spared his busy
Yeah,
clinical
thanks,
career.
thanks, Parikshit. So I'll be joining. I'll be connected for some more time, but then in between I'll have to log off. So thank you again for the opportunity to participate and also hear from my co-panelists. Thank you.
Uh, a panelist has joined us, Professor Vikas. Sir is an eminent neurosurgeon from NIMANS, Bangalore. Professor Vikas, am I audible?
So much for
Professor Vikas, am I audible? I think your audio is muted, sir. So meanwhile, we continue with the clinical discussion. So the next question to Vinny, sir. Uh, the areas which have been identified in clinical medicine, sir, they are quite generic. So do you feel that each field would have its specific requirements of AI? Like, for example, your field, sir, what are the specific areas of interest that you can identify, sir?
Okay, thank you for the question. So, when you talk about neurology, the field of neurology can benefit in terms of diagnosis from AI and in terms of predictions. And these predictions can be for clinical outcomes, like a patient who's had a stroke now, 3 months later, whether he would survive, whether he would walk, and if he has a disability, to what extent. Something like this can be predicted. Uh, Even death can be predicted from the initial capture of data. Similarly, whether uh, using an MRI template, feeding the MRI template, can you predict whether this patient is going to develop dementia in future years? Or by screening the retinal picture, whether the patient is going to develop a neurodegenerative condition like a Parkinson disease. All these are very much possible through prediction algorithms using AI. And also, I guess in neurology, you can also predict the treatment outcome by feeding the baseline data. Also, it is already being used in neurology where when a patient of stroke comes to an emergency, the initial CT scan that is done, suppose there's a very busy center and 20 patients with suspected stroke come in the evening. So the AI is already kind of triaging the CTs for the radiologist to focus the attention on. So this is also an emerging field where neurology may benefit from AI.
So, um, uh, Professor Vikas, I think sir has joined us. Am I audible, sir? You are still muted, sir. You can turn on the video and then speak, sir. I think your internet. So, Professor Vikas is interested in developing brain-computer interfaces. He's a neurosurgeon, an eminent neurosurgeon from NIMHANS, who works with implanting leads into the brain. And he had sent one video of his intra-op demonstration, so how to place echocorticograph leads. And that is what I had also discussed with Vinny, sir, that whether this is the direction where AI is headed. So that is why I asked the professor to join in today, but I guess his audio is not working. Hello, sir, Professor Vikas, sir. I think he can send. We can get his feedback later. So to conclude the clinical session, I invite the two senior clinicians present among us, Major General Vivekanand, sir, Sena Medal, Dean and Deputy Commandant, for his views on the impact that AI is going to have on clinical medicine in general, sir.
Yeah, thank you, Parikshit. I'm not an expert on AI at all, but as a clinician and as an anesthesiologist, there are about 2, 3 fields which I thought needs to be looked into and where maybe AI can help us. Anesthesia per se, over the last many years and decades, has improved in its safety. But where things can be further improved upon and where AI may